Hello, everyone, and welcome to CR Arthritis. My name is Ellen, and I'm the Programs Coordinator at Arthritis Consumer Experts. Today, I'm joined by Dr. Alexandra Saltman, who is an assistant professor in the Department of Medicine at the University of Toronto. Dr. Alex Saltman is also a clinician teacher in the Division of Rheumatology and Palliative Medicine at Mount Sinai Hospital and the University Health Network. And we very shortly will get to know what that means. Dr. Saltman recently presented a workshop at the conference titled Palliative Care in Rheumatic Disease. When does the end begin and why does it matter? And that is what we will be talking about today. Thank you so much for joining us, Dr. Saltman.
Thanks for having me.
Dr. Saltman, can you tell us a little bit more about yourself and perhaps how you're involved in both rheumatology and palliative medicine?
Sure, happy to. So this is an uncommon combination, as I imagine most of our listeners will know. So I actually was attracted to sort of palliative care and palliative patients from pretty early on in my training, even in medical school. Um, and when I decided that my clinical love was rheumatology, I looked at ways of trying to put the two together. And I saw over my rheumatology training that there was a population of patients with life-limiting rheumatic disease. So people with bad scleroderma, with vasculitis with end organ damage, or bad lupus with lung disease or cardiac disease or renal disease, or patients with myositis who also had a cancer or who had bad lung disease. And that these patients often had really bad symptoms and often quite a short prognosis. But despite that, they didn't really have access to palliative care services the way that patients with cancer or end stage heart disease or end stage lung disease have. And so recognizing that this population existed, I decided to try to develop a niche specialty at the intersection between rheumatology and palliative medicine, where I could help to provide both symptom management and also support for future planning for these patients. And then as I was finishing my palliative training, this whole new area of immuno-oncology came online. So new cancer therapies that harness the immune system in order for it to work against cancer. And these drugs called immune checkpoint inhibitors are very effective in lots of advanced cancers. But when we wake up the immune system, sometimes we wake up the immune system inappropriately. And that can mean that these patients can develop new autoimmune conditions. And that created a whole other population of patients with both rheumatic and palliative needs. So they were more palliative from an advanced cancer perspective and then developed a whole new autoimmune rheumatic condition. And so those are kind of the two populations that I take care of and where these two specialties intersect.
Such a cool and unique and in a story that really shows us not only your interests going through medicine, but how technology as well as treatment has evolved and how
Totally.
you truly found yourself in the middle of this two different worlds, but also so many of the same needs, so many of the same gaps that you're filling. So thank you for being in this specialty role. And for our audience, could you share with us how many, in this case, rheumatologists who are specialized in palliative care, are there in Canada? I think everyone would be quite surprised.
Yeah, so this workshop was a co-presentation with myself and my colleague, Dr. Adam Imlani, who practices in Richmond, British Columbia, and he is the only other rheumatologist in Canada who has formal training in palliative care. So there are just two of us, and I believe there's one in the U.S. And a couple in Europe. So we are rare birds so far.
Very, very rare. And with this specialized knowledge, could you share with us what is or what does palliative care in rheumatic disease look like? And perhaps how does it differ from palliative care more generally speaking?
Yeah, that's a really good question. I think in many respects it doesn't differ, but it's a little bit maybe less intuitive and certainly less well known. So really the big components of palliative care center around the approach to care, which really aims to improve quality of life for patients and for their families, for people who are facing all kinds of life-limiting illnesses. And this is really through kind of three main mechanisms: through preventing and relieving suffering, through controlling symptoms, and through addressing physical, psychological, and spiritual distress. And that's not specific to rheumatology, that's sort of palliative care for any life-limiting disease. And traditionally, I think most lay people and most healthcare providers thought about palliative care in this way, really only applying to patients who are at the end of life. And the big change in the last 10 to 15 years has been the realization that we can actually do a lot more for our patients by an earlier introduction of palliative principles alongside disease-directed management. And as palliative care has expanded beyond the treatment of just malignant conditions, I think we've started to recognize as a medical community that by introducing concepts of quality of life, symptom management, planning for the future, home supports, while people are still getting active treatment and when they're much more well, we can help not only with their quality of life, but also their quantity of life. And in the cancer world, we have some good data, particularly in lung cancer, that people actually live longer when they have early palliative care. So it's not just about feeling better, though I would hope that would be enough. But in addition to that, that we actually can help people live longer by introducing these principles earlier. And so Adam and my aim in rheumatology is to try to bring those principles in to our patients. So obviously not those who have really treatable diseases with low symptom burdens and good quality of life at baseline. And fortunately, for many of our inflammatory arthritides, we've had such advances in the 20th and 21st centuries so far that we wouldn't need these principles. But for some of our other diseases, as I mentioned before, like scleroderma, like certain vasculitides, inflammatory myositis, that's not the case. And so those are the patients that we're trying to target.
Absolutely. And like you said, even though we have so many advances in terms of biologics, biosimilars that, we continue to do research on, there are still certain populations that need specialized care. And even though it may seem similar or be similar, these principles need to be integrated earlier on. And your presentation or your workshop at the CRA, I am assuming was on this topic, and it was geared towards clinician and clinician scientists like yourself. Could you share with us a little bit more about some of the key messages or the key takeaways?
Sure. So our workshop was interactive, and we had a nice broad audience. Lots of sort of people who are earlier in their career, including some trainees, and so we talked quite a bit about the literature to date, which is pretty sparse. And so we talked about how there really is not a lot of data around integrating palliative care in rheumatology, but that the data we have shows us that rheumatologists don't have a lot of comfort, knowledge, or experience in having these conversations or in implementing these principles, and that patients with life-limiting rheumatic diseases, we'll use kind of scleroderma as the prototypical disease, often have symptom burdens that are akin to those of patients with advanced cancer, but their access to palliative care is terrible, like less than 5%. And so Adam spent some time kind of walking through the literature to share some of the studies that underpin the statistics that I just quoted. And then we spent some time going through some cases of real patients that I've taken care of in my clinic who illustrate some of these principles and to demonstrate where we can make an impact by bringing in palliative principles, and in some cases actually a palliative specialist to help with symptoms, with home supports, and with planning. And then we wrapped up with talking about directions for future both empowerment of rheumatologists to be more bold about involving palliative care clinicians and raising the topic of palliative care involvement with the right patient at the right time. And we had lots of debate in the room about how do you do that? How do you know when to do that? When is it appropriate for you to have the conversation versus referring to somebody else or asking the family physician to be involved? And I think we all left with, some questions, but I hope some answers and some approaches as well. And our vision is that this is the first of hopefully additional future opportunities for engagement where we can try to build capacity within rheumatology.
Yeah, very sensitive topic. And like you said, in medicine, four-year degree, individuals who don't specialize, so rheumatologists strictly speaking, don't have training on how to have these conversations, when to have these conversations, who to reach out to. But I'm hearing, like, again, this call for cross collaboration between disciplines, right? Because there's only so many of you, Dr. Saltman, even though we wish we had more individuals who had the dual specialty. We know that there are other individuals that we can call on to the team. Can I ask, what are some of the latest innovations that you're looking forward to implementing your work? For example, is there a next step to this?
Yeah, that's a great question. I think one of the innovations that we've started locally that I hope we can share across the country is that with some of my colleagues who also work in non-cancer palliative care, we've started to do training workshops for both trainees and interested faculty around how to have these conversations. And so we've done this with rheumatology trainees in Toronto. We've done this with respirology trainees and with general internal medicine trainees. And so this is not, the only type of difficult communication workshop out there, but we've tailored it specifically to these specialties and to the patients that we see. And so I think that's one innovation that I hope we'll be able to share with our colleagues across the country to, with the view to building capacity so that you don't have to be a dual subspecialist in order to at least start the conversation and point your patients in the right direction when it's appropriate to do so.
That's incredible. We hope, again, like you said, this catches on very quickly. Um, and in your opinion, what are the keys for success in terms of putting these advancements into place? Like, what would it take for this training to go to every university that has a medical school or has medical faculty in Canada?
Yeah, so I think some of it is capacity, sort of both person capacity, interest, engagement. Time is money, and so sometimes it's the time, and I also think it's the buy-in. And so one of our purposes for doing the workshop at CRA was to sort of try to demonstrate to our colleagues, some of whom may be more or less inclined to be open to this area, that by engaging in these conversations, it doesn't mean that we are destroying hope or giving up on patients, so to speak. It's that we're enhancing the quality of care that we provide and actually hopefully improving the patient and family experience by addressing a really important element of advanced disease that is missing in our specialty. So I think that's probably step one, even before we look at the logistics of the who, where, when around the training is how do we get people to speak this language and recognize the importance, and then the rest comes after that.
Absolutely. And do you have any other insights you can share to improve a patient's disease journey, their self-care, or their self-advocacy?
I think if there are patients listening to this, for people who have rheumatic diseases that are more challenging to manage, there is always a place to ask for additional support in this regard. And whether that's a palliative consult or just having a conversation with your rheumatologist and or your family physician around, what other things can we do besides the rheumatology specific kind of immune targeted treatment? What else can we do to help my pain or my shortness of breath or my other symptoms? And what other supports are there for me in the community that can help me to have the best quality of life for however long that is?
Absolutely. Again, message very, very clear to all the patients who are listening. If you're experiencing some symptoms that are more challenging, look around, dig for the resources in your community, have conversations with different care providers. And in this case, fingers crossed that more training comes to a university near you, to a center near you. But Dr. Saltman, thank you so much for your unique perspectives, the work that you do that is so fascinating, and for sharing some time with us at Arthritis Consumer Experts.
Thank you so much for having me. It was lovely to chat with you.
And with that, we're going to thank our audience. Thank you for joining us. Make sure to check out our other episodes. And with that, we hope everyone has a lovely rest of their week. Goodbye for now.